very good morning. Thank you, respected chairpersons. At the outset, thank you, Team Diabetes India, Dr. Bansi Sabu, Dr. Rutul, and everyone for having me today to speak on a little different topic of current goal of type 2 diabetes treatment. Is good glycemic control enough? So, as we have been learning from last 3 days, a lot of been spoken about diabetes, and what we are trying to understand is that diabetes is turning out to be not only about glycemic control, it's turning out to be more about a cardiometabolic, renal, and vascular. So the approach is going to be more focusing on the cardiometabolic part, vascular, and renal part. And that's what we are also going to be understanding in the next 12 to 13 minutes of my talk. So earlier was the days where the aim of treatment of diabetes was only about good glucose lowering. The management strategies were planned that way, molecules were that way, that they aim at a good glucose lowering. But times have changed. Currently, we are looking at not only a good glucose lowering, but low risk of hypoglycemia, something which is cardiorenal safe, something which has a good durability and sustainability, ease of dosing, very important, and weight new loss or at least weight neutral molecules, what we are looking at. So the whole scenario changed from 2019. The approach towards diabetes management changed. So it went from a glucocentric approach to a more comprehensive and a vascular approach. And that's what we are going to be understanding now. So the way ahead is not simple now. The way ahead is little more complicated. We are not only looking at a good glycemic variability and reducing the macro and microvascular complications, but we are looking something additionally also. We are looking for sexual well-being in our patients, a good mental health, and we are also focusing on the muscle, fat, and liver. So when we talk about CVOT trials, what was in the previous era, that in the early era, the most important focus was on HbA1c. You bring down the HbA1c, the molecule is good. But times have changed. Studies have now shown, especially after the rosiglitazone fiasco, it has become mandatory that every molecule which comes to hits the market, before it hits the market, it has to undergo a good cardiovascular trial. And now with the newer molecules like SGLT2 inhibitors or GLP-1s, CVOT trials have shown us so many benefits in our patients with diabetes. So, when we talk about a good glycemic control, does it only mean an intensive glycemic control? Prioritizing tight glycemic control to prevent chronic complications is well known. What we know is a good glycemic control is considered as an essential strategy to prevent chronic complications. Even the practice guidelines, quality improvement programs, and most of our clinical care programs all focus on tight glycemic control. But when we talk about tight glycemic control, is it enough? What do studies have to say? So, even the studies have said that with good intensive glycemic control, what we gain is a reduction in microvascular complications like retinopathy, nephropathy. But what about the macrovascular complications? There is mixed data. So, there is limiting benefits when it comes to reducing the impact on non fatal MI. But what they saw in majority of the trials was no significant benefits were seen on stroke, heart failure, or mortality with these molecules. So, what does it say? That we have to look a little beyond. Then comes the time of re-evaluating the glycemic control. The importance of reduction in 1% A1C cannot be undermined. I think in my previous talk, Dr. Arvind also mentioned this, that if we bring down the A1C by 1%, there is reduction in cardiovascular mortality, there is a reduction in microvascular complications and death related to diabetes. But we are looking for something beyond. We are asking for something more. Before we go to what we are asking, there was this beautiful paper like Monnier where he tried to look at the legacy effect a little more deeply. We all talk about legacy effect from after the UK PDS studies and after the other trials where they looked at the long-term follow-ups with advanced trial, ECOT study, VADT, where reduced chronic exposure to glucose throughout the interventional period. What he is saying is that A1C decrement and duration of improvement improvement during the active intervention period range from 9 to 15 percentage years. So what it suggests is that this effect will be evident maybe after 10 years if the A1C decrements was from baseline by 1% during the periods of intensive control. So is this enough? Are we not looking at short term benefits for a patient who have more of glycemic variability? So there comes a paradigm shift from the glucocentric approach in our patients to a more organ protection in patients with type 2 diabetes. And if you look at this paper by Mr. Stephen Jacob, it is a beautiful paper where he described this into three eras. The first era is glucocentric approach. Second era is looking at glucocentric approach with less risk of hypoglycemia and no weight gain. And third era was all of the above with end organ protection with focus on cardiorenal outcomes. Now let's understand all these eras a bit in detail. So the evolution of treatment recommendations has also been changed. So if you look at the ADA-ASD guidelines in 2009, the main target was A1C control. The strategy was it is lower the A1C, better it is. Move to 2015, they looked at a little more that lower the A1C, better it is, but without any risk of hypoglycemia and weight gain. A few years ahead, they realized this is not enough too. We have to look at cardiorenal benefits, but looking at reduction in not only a good glycemic variability, but reduction in blood pressure, good effects on dyslipidemia, and so we now need agents which have proven efficacy and safety. A detail about each era in couple of slides. So the first era where the ADA-ASD consensus statement in 2009 where we focused only on hyperglycemia control, lowering down the A1C. The molecules available at that time were also limited. We had insulin, we had sulfonylurea, and we had metformin. Not too much available for the treatment of our patients with diabetes. Even the earlier trial were focusing on reduction in A1C. The landmark trials at that time were UGTP and UKPDS trial, which started demonstrating benefits of a good glycemic control on reducing the microvascular complication. And it cemented metformin as the first line therapy for our patients who are overweight or obese. In the first era also they had challenges and legacy effects. So UKPDS highlighted limitations in proving cardiovascular benefits from these glucose lowering agents, and the legacy effect of metformin on myocardial infarction was observed in the post trial period, but with some caveats. Then they also understood that from the UKPDS hypertension study that using good molecules to bring down the hypertension also helped in cardiovascular benefits. Same was seen in Steno study with use of statins for bringing down the lipids. But still the focus remained on a good glycemic control till then. Then came the second era, where the key findings from most of the big trials like the ACCORD, VADT, advanced trial, they started seeing that the tight glycemic control helped. But ACCORD, we all know, was terminated early because of the 22% increase in mortality in the intensive control group due to hypoglycemias. Again, it was looked there was a little focus given on that increased risk of hypoglycemia and weight gain was identified. So because hypoglycemia led to cardiac arrhythmias and increase in mortality, so now they started looking at molecules which were more safer. That's was the time when thiazolidines and AGIs were introduced. So thiazolidines they saw avoided hypoglycemia but still pose the risk when combined with other agents. So in the second era, in the ADA 2015 EASD consensus in 2015, now they saw that we have the legacy effect was questioned. There was shift in the management philosophy. The ADA guidelines were revised. They advocated for a more individualized A1C targets needed for patient benefits, emphasizing balancing a good glycemic control and minimizing the adverse effect. But there was a continuing debate, ongoing discord between research evidence and clinical policies regarding the tight glycemic control. In 2015, A1C still remained a major focus, but we were trying to broaden our horizons by then. So, because the evidence was starting to show that we could only bring down the microvascular complications, what about the macrovascular complications? And there was a call for re-evaluation. Then came the third era. In 2018, ADA ESG statement shifted focus from transitioning a good glycemic control, prioritizing that, to reducing cardiovascular renal complications. So now we started emphasizing on the hard clinical endpoints like cardiovascular events and renal outcomes. Landmark trials, we know EMPA-REG, but leader trial, many CVOT trials came at that time. And again, that was a time when the rosiglitazone fiasco came out. So after that controversy, FDA mandated the CVOT trials to ensure the safety of the molecules which were used in our patients with type 2 diabetes. So the key findings from major trials with especially SGLT2 inhibitors, GLP-1 analogs and DPP-4 inhibitors started looking beyond a good glycemic control. Benefits extended to primary prevention in patients with multiple cardiovascular risk factors. So now there was a paradigm shift in the personalized therapy. We had newer molecules which had proven benefits beyond a good glycemic control. So, in the third era, there was a broader impact, cardiorenal benefits confirmed in non diabetic patients. We have seen with SGLT2 inhibitors, with landmark trials that they went beyond in patients with type 2 diabetes. They had benefits to offer in terms of cardiorenal advantage in patients who did not have diabetes also. So the future implication is a potential for a fourth era where these agents are widely used for cardiorenal protection regardless of their diabetes status. Integration of CVOT findings into treatment guidelines by the cardiometabolic societies, but still challenges do remain in implementing evidence-based guidance into routine practice. This is just a list of the major CVOT trials which made the huge difference in our thinking perspective and broadening the horizons. Just a slide about showing that how glucose lowering agents have also moved over a period of time from the first era where we had sulfonylureas and insulin to introduction of carbos, DPP4, thiazolidinones, and then we have newer agents like SGLT2 inhibitors and GLP-1 analogs. Trials have also shifted from the first era UKPDS to Accord, VADT Advance, and then to the EMPA-REG and Leader and Sustain and such big trials. So the shift in diabetes management from solely targeting a good glycemic control to emphasizing on organ protection incorporates strategies to address the cardiovascular, renal, and overall health outcomes. So this is what the whole shift was about. So what does our own recommendations come from? What do the recent guidelines say from the ADA 2025? So the standard of care to diabetes by the ADA 2025 says that we have to focus on a person-centered collaborative care with a comprehensive medical evaluation. They have kind of redefine that whatever you're looking at a good glycemic control, but with ASCVD they have guidelines. You can start with GLP-1 SGLT2 inhibitors. With the patients with renal benefits, start with again GLP-1 SGLT2 inhibitors. If you're looking at weight management, these molecules are going to be helpful. So the ADA also now emphasizes on these four pillars where glycemic management, good blood pressure control, good control on lipid management, and agents with cardiovascular and renal benefits, where lifestyle modification and diabetes education is not at all undermined, is the way to go ahead in our patients with diabetes. So the future definitely looks promising. Inculcating all this multifaceted treatment strategies for holistic care is going to help our patients go a long way. Thank you all for your patient hearing.